We're back on track. So we're moving very quickly into CDC website. And Eileen, if you'd just like to open that presentation discussion for us. So Eileen Holderman, thank you very much.
Okay, thank you. Eileen Holderman, patient rep. I'm going to talk briefly about the CDC website, and I'd first like to thank Dr. Mike Miller, who retired. He was responsive to the advocacy community and other stakeholders who were concerned about the content on the CDC website, and he asked me, Nancy Klimas, Dane Cook, and then later Steve Kravchuk to review it and submit comments. We had a teleconference. It was productive. And we asked Dr. Unger for an extension. She granted it to us. And she asked for our comments to be sent individually if we could. So we did, and everyone submitted comments. During that process, we asked, it came to our attention that a medical doctor and advocate named Lily Chu was conducting an independent study on the CDC website. So we incorporated her comments in our group, and we submitted everything to the CDC. As my participation, I asked Dr. Unger if I could have teleconferences with her, and she graciously accommodated me. We had 3. The first one was with myself, Dr. Unger, Dr. Belay, and John O'Connor from the CDC. And we all sat at our laptops, and we navigated the site, and they gave me the floor. They were gracious, attentive, open-minded, and listened to a lot of the concerns that have been conveyed to me over the years through advocates and other stakeholders, and some of my own personal concerns. And I thought it was a very productive meeting. The second teleconference I had was with just Dr. Unger, and we centered on the CDC studies, particularly the ones that the advocates are concerned about, such as the childhood trauma and the childhood adversity studies. So we talked about those in particular, and Dr. Unger sent me links that said, you know, there are other studies that support that premise, because I did challenge it and say that I didn't think it was really replicated or embraced by mainstream science, and she sent me links which I have to look at. I haven't yet, so it's been an ongoing process. And then the third teleconference was with Dr. Unger and myself again, and this one I looked at other CDC websites that were for other disease groups, and I drew on examples that I thought were positive, examples that we could incorporate into the CDC website. Things like links to other organizations, such as on the heart disease CDC website, they incorporated the American Heart Association, and the lung website for lung disease had something called Love Lung, or it's some organization, I don't know, I wrote them all down. But I saw a lot of good examples, and Beth and I sat at our laptops and we went over them. And, you know, she did point out that some of the examples I was giving, you know, as to other outside organizations were indeed government organizations, and she you know, pointed out that unfortunately, Eileen, we can't put on our website what we don't have. We don't have those same types of organizations for CFS, and that's true. But at the same time, she sort of made my point, which is there is an inequity that I feel in regard to CFS. We would like to see, you know, more of the same resources, funding, and content that is found on other websites on the CFS website. We concentrated on 3 main things: tone, language, and content. As far as tone, I was looking for a respectful tone that I thought wasn't there, eliminating sort of a sort of scolding or condescending tone. Language, I was calling for more descriptive and medical language that was strong and scientifically accurate, and content, looking for the CDC to showcase their body of work and not focus so much on the psychological studies, to be more inclusive of all of their studies since it's a multi-system disease. And we also discussed, well, we didn't discuss, but we said it would be an ongoing process, and she would carefully look at, you know, all of the comments submitted by Dane, by Nancy, Lily, and Steve and myself. And before they make a comment, they're all going to make a brief comment. I also wanted you to know that in our subcommittee for education and patient quality of life, we had on the agenda for both of our meetings the CDC website, because it does affect patients' quality of life when it comes to insurance reimbursement, how the disease is portrayed, the fact that the media accesses the website and can do some damaging reports, we feel, if the website isn't updated or reflect properly what the disease is all about. So our subcommittee members reviewed the website and made comments, which we forwarded to the CDC. We left off the names, not that any of their comments were at all, you know, not fair. They were fair, and we just chose to do it that way. And again, CDC was very gracious, very open-minded, positive about this, accommodating, and it was a good experience. We also invited both Beth and Ermias to the subcommittee meetings, and they have come. And we appreciate that very much, and we appreciate the ongoing dialogue that we have started. It's a huge website with a lot of content, but it's important. It's been a very hot topic for the advocates in particular. And the only two areas that we did not address were the toolkit and the CME. These are probably the two most important aspects of the website. We didn't get to them. We didn't want to rush through it. And I know Lily Chu is, you know, she's looking over the toolkit, and Nancy Klimas will talk on the CME. And I think that's all I've got to say, other than to thank the CDC for starting the dialogue, and to thank everyone on the review panel and the subcommittee. And now, I guess, Nancy, does Dane, you want to go ahead, Dane?
Sure. Dane Cook, UW-Madison. First, I'd like to thank Eileen for being the engine behind this. She really put a lot of effort into this, and obvious from her report, into conducting the review of the website. And as she said, we were asked to give individual accounts of our review of the website. I went from the scientific perspective because that's where I have my the most expertise, and I had 3 general observations. The first was that I didn't think that the website was wildly inaccurate, and it contained a lot of useful information, but I could understand where the patients would find it or could find it offensive in language. And so I agree with our committee, and I'm in agreement with our recommendation that the CDC website's tone could be improved dramatically. The second observation was that the impression I got was that the information presented really seemed incomplete and in many ways was cherry-picked. And this was most apparent to me in the causes section. And there were many areas of research that just simply were not represented. And whether this is due to the CDC simply presenting their information and not the rest of the field's information, I'm not sure, but that was my second overall impression. And then the final observation that I had on the site was that the information was presented inconsistently. And what I mean by that, it was varying between reporting fact on the site that was data-based and opinion. And so there were several value and judgment statements, and I pointed these out in my report, that seem more to be the bias of the CDC rather than the consensus of the scientific community. So if the CDC has stated several times at these meetings that their information is based on the evidence and on the data. And there are simply too many examples on the website where that is not the case. And so if this is going to be an informational website, and I think that it should be an informational website, then the information should be as accurate, up to date, and based on consensus of the scientific community as possible. And I believe that the CDC site does need to be a comprehensive site. And it has to be a comprehensive site for the patients, for the physicians, and for the scientists. That's my review.
I'm speaking about the CME, Nancy Klimas, Miami. Lenny Jason, DePaul University. No, Nancy Klimas, Miami. The CME, is under revision. The CDC, in a very proactive way, well before the time that we started reviewing the website, had already engaged a process to update the CME. I think I was notified in January. Ann's on the committee, Cindy Bateman's on the committee. I forget everybody else, but this, Jim Jones is chairing, and there's a number of CDC education experts and process experts on the committee. It's quite a process. We're currently meeting once a month by conference call. We've taken various parts and we're revising and changing it. So I think the anticipated date of completion is in the spring, or launches in the spring. So rather than take this CME apart, it would seem more reasonable to be engaged in the process of the new CME process. So it's very good and well underway, and I think Cindy Bateman's been amazing. She, as always, Cindy Bateman's amazing, and she's really motivating all of us to push on. So thank you.
And now, if the CDC would like to respond, Hermes or
I think
Elizabeth?
Steve just had one comment.
I was pleased to find out after our meeting that there is a link to the Social Security regulations. However, the pathway is somewhat obscure to the person coming in. And the suggestion I would make, having looked at it, is if you're going to try and help people understand what disability is about, that a couple things could be done. One is put disability in your initial list of things on your front page so that it could get to it. I think it was under, I don't remember what it was under, but it was something that wouldn't intuitively take me there as an attorney, let alone as a person looking. Secondly, there are really two types of problems, or three types of problems that people with chronic fatigue syndrome are going to have. They're going to have post-exertional fatigue, and they're going to have cognitive problems. So it'd be useful to have the scientific data that relates to those types of problems and how somebody might go about documenting those types of conditions, because most people don't know, and that would be very relevant to the patient community and probably pretty easy to put on the website. Thank you.
Chris?
Eileen Holderman.
Eileen Holderman, just one final comment. I noticed a couple weeks ago that the CDC site has begun to change, and you can see that the pages have been modified, and that's a positive thing. Anytime it's moving in a forward direction, I'm really happy about. The biggest premise for me, and I'm only going to say one thing, because I know my time is up, is that I really wanted the website to reflect chronic fatigue syndrome, not chronic fatigue. And the very first thing that you see on the site just described chronic fatigue. So I noticed a couple nights ago that that has been changed. I'm happy for it. I want it to go a little bit further because it could still sound a little like depression now. I'd like to see like the fevers right on, you know, the swollen lymph nodes and the things that are really unique to CFS, not that could be misconstrued as, you know, overlapping illnesses like depression or CF or idiopathic chronic fatigue. So I just wanted to say thank you for starting to make the changes. Thank you for opening the dialogue. And just thank you.
CDC.
Ermias Balai from CDC. I just wanted to summarize the objective, the primary intent of the website as we first started creating the website. The primary objectives were to raise awareness about CFS, to educate the public health community about the disease, and also provide basic scientific information to clinicians. I believe we have achieved that goal to a certain extent, by and large, and we have a lot of visits to the website. So a lot of people visit the website and get information from that website. And more people, I believe, have become aware of CFS because of the information on the website, and that's the positive. And this has happened over time, and not just in a short period of time. That is not to say that the website is perfect. I don't think there is any website that's perfect, and I don't pretend to say that. And by nature, you know, websites should be reviewed. You know, by nature, they should be updated on an ongoing basis, and ours is no exception. So we're committed to updating the website as more data and more information becomes available, and also input that we received from the committee. But just to historically go back to how this review process started, is during the last CFSAC meeting, Dr. Nancy Klimas, I believe, raised up the issue that some insurance companies were denying coverage to some laboratory tests, citing information on the CDC website. I think this is the reason that review process got initiated in the first place. And clearly that was not our intention for the website, you know, for other people to misuse the information in ways that would harm patients. That was not our intention. But at the same time, we can't prevent people from misusing or misinterpreting information on our website. Our duty is to make the information as clear as possible so that it would not be misused. So as Eileen and the others have already indicated, we received input from at least 5 individuals, the committee members that were selected, but by Dr. Mike Miller, and also from Dr. Lily Chu, that was selected by the committees, the selected members to provide input on the website. We just received those comments about several weeks ago. We've not gone through all of them. We're still continuing to review the input, the comments that we have received. But because of the history that the information on our website was being misused to deny coverage, we gave that part of the website priority during our review. And we reviewed that part and we've changed it. And that's basically what Eileen was commenting on mainly. So that website that was brought to our attention that's being misused, we've already changed it. And hopefully would not be misinterpreted again. And we're committed to reviewing all the comments that we've already received from the committee members and from Dr. Chu, and make adjustments as possible. We have agency rules that we have to follow, and we have clearance processes within the agency that we have to go through. All information that's put on our CDC website goes through a scientific clearance process within the agency. So we need time not only to review the comments, but also to clear them through that scientific review process. And I could tell you that process is ongoing. I would like to thank the committee members who actually took the time to review all parts of the website and provided their comments, including Dr. Chu. And I don't think Dr. Chu is here. She's probably on the line. Right. So thank you, Dr. Chu, for providing the comments. And she provided extensive comments on the website. And it takes time, believe me, it takes time to go through all the information that's on the website. So thanks.
Nancy Klimas.
Just to brainstorm with the committee for a moment, is there any way to undo the damage? Because at this moment, there are policies in place with these third-party providers that are quoting the CDC web page in denying tilt table tests, sleep studies, and so on. Clearly, they misinterpreted the intent of the web page, but nonetheless, the policies are in play. So is there any HHS agency that oversees third-party reimbursement? I mean, how does that work? How do we make them shift established, well-written policies at this point? Is it?
I can answer that. There isn't any federal government that oversees that area for private, like insurance companies that are around. They're regulated by states. Outreach maybe, but
yeah,
not
everyone's
control.
pointing to me. So this
I'm
is
not.
Elaine Perry with CMS. Sorry, I'm not an expert in this area. My understanding is that most insurance regulation is done by the state. With the Affordable Care Act, there have been some changes. I'm not clear right now what the boundaries are and exactly what the federal role is. However, that is a question that I can research and get back to the committee on.
Yeah, I mean, this is Steve Krafchick. Insurance policies are regulated state by state insurance commissioners. The only place that the federal government has any interface are the HRSA plans, and those cover a lot of people, so there could be some movement in that area that's regulated by the Department of Labor.
I was just going to add a couple of comments myself, because I did take a look at the website, and I agree with Dane that there is a lot of good information on there, but there's also a lot of not so good information, and it tends to be given equal weight. You can't always tell which should be given priority. And in part, I think it's because it's a poorly designed website. And what I'm going to suggest is that fix the things that need to be fixed, but what should be happening is somebody should be working on a brand new website designed from scratch that reflects up-to-date technology and up-to-date approaches to putting together a website. Because I think just doing it piecemeal, there's always going to be things there that are problematic. And it looks like almost like a history of chronic fatigue syndrome, that everything that's ever been discovered or thought about the illness is still on the CDC website. I mean, we're able, with inside knowledge, to be able to filter things that are inappropriate, but not everybody is. And you can also, if it's not conflicting information, it's competing information. So you can choose A or B, and each seems to be equally valid. So that would be my suggestion. And one other comment that has already been made over this couple of days is the link to St. Bartholomew's, and I'm not sure how productive that is. And why it was put in there. Is it because CDC didn't have their own information on those topics? And it almost feels like, one of those ads that jump out at you when you don't want them to, when you click on the wrong thing. So I don't know how easy that is just to remove that link. It certainly is not a government organization. So just my 10 cents worth. Susan Levine.
Hi, Sue Levine. I just wanted to get an idea of the timeline that you intend to make these changes, especially the ones that involve patient care and reimbursement. Do you have any idea how long that will take to write those changes in, and, for instance, tilt table tests and so on, so that patients can get reimbursed?
I think we should be able to do it within several months. The table part is already done, is what Beth is telling me.
Can we get an update from you at the next meeting? At
Oh,
the
yeah,
next CFSAC meeting?
Absolutely.
Leonard Jason.
Just wanted to get a sense from the CDC as to what's the process by which you get approval for making these types of changes, and how, as you're making the changes, you can stay in touch with some of the people who have been giving you feedback, and how those decisions potentially can be made between now and the next CFSAC meeting.
Well,
Identify yourself.
oh, sorry, this is Beth Unger from CDC. The process is that we are going to be, we've already started looking at the content, and while we were not planning an entire revision of the website, but to incorporate all of the changes will, just by its nature, require some revamping of where it's going. We did not intend to do something and then come back to the committee and get approval on it and go back and forth like that. We think that we need to move forward with the input. We think we understand the issues much more clearly. And I will say that having the conversation was really very important, because there were things that I never in a million years as a physician would have taken offense at. For example, patient's report is a standard practice, and yet that was perceived as not good. We've had discussions in our group whether we should do a focus group on this, whether we should involve a special consultant. And we have to put the web page sort of in the context of the whole program. We don't have huge resources. We're tapping into CDC's web page designers and trying to fit into the process. And so that we don't take a lot of our program dollars and time just trying to keep a balance on this. So exactly how much of a revamp on this will be, I think we need to get a little further into it. But the process is that once we have our content put together, we submit it to the division. It's reviewed there on web page issues. I think it goes through the center, and comments are made, and then it needs to be made 508 compliant. It gets put up on a test platform, which then people review and look at and make sure that it's okay, and then it goes live.
I really appreciate both Ermias and Beth being open to these changes, and I certainly appreciate taking the changes, going over them, and not coming back and having us re-review. But it certainly would be helpful for us to get a sense of your take on our suggested changes. We don't know where you're going with it as it currently is. We don't know your interpretation of what we've provided, the information we've provided you, and that would go a long ways towards us knowing whether or not you're heading in the direction that we had hoped or intended.
Well, our take is that
Beth Unger.
Oh, sorry, Beth Unger. Sorry, it's much harder than it looks from sitting out there. Our take is that we certainly we can understand the comments, and while we might not change it exactly the way that the commenter had in mind or suggested, we will address those issues. So it's very clear where the problems are. There are some really simple things, like it was a lot of concern that we were presenting only CDC research, and that that was only to just provide information on what CDC was doing, not to be a comprehensive research review of CFS. That was in the paragraph above, but obviously it's not clear, so we're totally taking that down and only providing references of what the program has done to minimize that and make it clear that this is not a research review. And
am I to understand that you do not intend it to be a comprehensive site?
No, it was not intended to be a comprehensive research site.
Can you tell us why the government agency that studies CFS wouldn't be a comprehensive site for CFS?
Well, again, we're going to our priority and what our priority mission is, and we want to make sure we are getting out to the clinicians and to the patients, and describing what is known about the illness and keeping that part updated. We think that PubMed and other resources are available for researchers to find out the latest research on CFS. And CDC's, we actually have an ongoing debate at CDC about how much research to put on our network, because it does get confused. If the public goes there, it sometimes is hard to understand what is accepted. Just as you said, we blur the lines, accepted versus being investigated. So that is why we made that decision to separate that. So the research part is really small.
I can appreciate that that sentiment and that thinking, but at the same time, as research informs the clinic and the clinic informs research, I'm not totally on board with that approach.
Nancy Lee had a comment, and then Steve will be the final comment for this session.
I just want to say that CDC is not the only federal agency doing research, and I'm not sure about the relative dollars in there, but they're definitely not the only one. This particular part of CDC is a virology division. So they would have, pardon?
With a long-standing CFS
Well,
research
but what I'm saying
program.
is you don't have physical, you don't have exercise physiologists in this group, you don't have behavioral scientists, and so.
You do. I mean, Nancy, you don't understand. This is a very interdisciplinary group. It's Nancy Klimas-Mamie. The CDC is not doing virology. That's a problem with some of the research community. They are doing everything interdisciplinary, and they have some excellent science to back up their work. If they're going to review their own work, big label CDC's ongoing work, that's fine. But if, as Skit suggested, and it's very true, a person goes to the CDC website, the clinician in the ER or anywhere else goes there to try to better understand the patient they have in front of them, and there's not at least some attempt to lay out the pathogenesis and the state of the science, if you would, on chronic fatigue syndrome, they're not going to go to the NIH site. What primary care doctor in the ER goes to the NIH to try to find out how to care for the patient in front of them? So we need to, this is the site they go to. It's the guidelines place. It's the place we all go to try to find out
And that's the point I was trying to
on.
make, Dane Cook.
Beth has a response.
Yes, this is Beth Unger. I think there's two areas on the website that kind of deal with these issues. We do have a section on pathogenesis that does need to be updated, and that is one area, but that's in very broad terms. It's not, detailed references. It's just kind of what the current thinking is of possibilities. Then our own research area, which was provided for information only, is the area I said that we are going to really shrink down, so it's not highlighted. It's just there as sort of a public documentation that the program has publications. That we also were asked to, consider links to other sites as appropriate in that area. That's also being, reviewed and considered what we can and what we can't do within policy. So the whole process for this is that we have begun, and hopefully by the next meeting we will have the changes already implemented.
Thank you.
The really positive outcome here is that there are lines of communication that are open, and we're learning how to better communicate every time that we do it. I'm not hearing anybody say no to anything at this point, that everything is on the table for consideration, and I just hopefully the process will continue, and it can only lead to improvement of the CDC site, and eventually we'll get it perfect, right? So, did you have a really important comment, Steve?
I'd like to make it, if I could. I think you can't put your head in the sand, and I'm not saying you are, and you have to recognize that the use of the website is going to be greater than you anticipate, particularly in the incidence of disability carriers or health insurance carriers. And to that end, rather than ignoring that it might be used that way, take a degree of sensitivity to that, because I think if you do that, that'll solve a lot of the problems. Also, I think somebody just made a comment that you could, PubMed has this information on it. Well, you have a link to that already. If it's specific enough to take people there, or maybe there are other sites they should go to get that current scientific information. Ways to keep you from having to review it and summarize it rather than go forward. But there's so many things that can be done, and I really appreciate the openness to try and see how we can make it better for everybody. Thank you.
Last comment to Eileen.
Thanks. I just wanted to add that I mentioned briefly to Beth, and I'm hoping that the line of communication that we started will continue. I would love to see a medical press kit on the site, because besides the two areas that Steve pointed out that are very important, our media, unfortunately, can do quite a bit of damage. Dr. Nancy Snyderman did a report, and she took everything straight off the CDC website so that anyone who could have been very, very ill with this disease gets that soundbite on TV that says to use the treadmill and go to a counselor. Primarily, could inflict some damage because of the restraints that a small soundbite, the media can't do justice, this comprehensive disease. So that's the other thing I want to try to address, that we need that. And thank you for everything again, and we appreciate it.
Okay, thank you very much. Productive conversation. We're now going to move on to the remaining agency updates. And so, does that qualify as your update for the CDC? You have some more information.
A little bit more information.
Okay, but any questions relevant to this, probably we just leave the website alone for the moment, and so keep it pertinent to the update. Thank you.
To make it easier for people to follow, I have some slides that I would like to load. So we'll have to take down plenty, sorry. Thank you, Ermias Balai from CDC. I prepared slides to make it easier for people to follow as I provide my report. This report basically summarizes our activities since the last CFSAC meeting in May. Let me see if I can advance the report. Okay, like many of you in the committee, the staff from CDC attended the IACFS-ME meeting organized in Ottawa. 6 CDC participants attended the meeting, and there were 8 oral presentations that were given by CDC staff and 1 poster presentation. In two of the sessions, our staff had actually chaired and co-chaired those sessions. And just about a week ago, 2 of our staff also attended the American Public Health Association conference that was actually held in this city, in Washington, D.C. In the CFS educational material, CDC had a booth. CDC always has a booth at the APHA conference. As you know, the APHA attracts the largest number of public health professionals to the meeting, sometimes over 20,000 participants. So it was an opportunity for us to continue educating the public health community on CFS. So at the CDC booth, we had CFS educational materials that were displayed and also distributed to the participants. At the same time, we had a CFS public service announcement that was aired or displayed at the APHA theater. There's a theater, an area where you could actually run DVDs continuously. And we did that at the conference. This public service announcement was actually produced as part of the 2006 information awareness campaign by CFIDS. And we have continued to use that PHA to raise awareness about CFS. And with some luck, For those of you who have not seen the PSA, because it's a very brief PSA, I would probably show it to you on the next slide. If you could double click on it.
The worst part isn't always waking up exhausted with legs that feel like lead, or that my memory is shot and every muscle in my body is screaming. The worst part isn't even that everyone thinks the problem's in my head. The worst part of chronic fatigue syndrome is missing my life. CFS affects more than 4 million Americans. Get informed, get diagnosed, get help.
I could provide you with the DVD if you're interested. Anyway, it's a 3 minutes brief PSA that was aired at the APHA. Yesterday there was a lot of discussion about education and continuing to raise awareness about CFS and educate different groups about the disease. And since the awareness campaign that was done in 2006, we continue to do whatever we can as resources allow us to continue to educate different groups, public health community mainly. Continuing with the publications, the scientific meetings, Dr. Unger attended the New Jersey Chronic Fatigue Association meeting in October, and she was the she provided the keynote address at that conference. And since the May CFSAC meeting, 5 publications by CDC authors on CFS were accepted for publication. And we participated in other meetings that are listed there. Now, we continue to meet with patient advocacy groups, and this started a while ago. And in May, since the last meeting again, CDC staff have met with Pandora and with the International ME Association in July, with the organization in Georgia in September, and additional meetings are planned in the future. This is as part of reaching out and interacting with the patient advocacy groups as needed, as necessary. The other activity that we had was, again, continuing with the education and public awareness. We hosted what we call the COCA call. This is the clinical outreach and communication activity that's developed by CDC mainly as part of the emergency response activity for other diseases. We took advantage of that call to provide a seminar on CFS, and 3 participants actually provided that seminar on the COCA call, 2 from CDC and 1 from Emory University. At the time of the call, there were 45 webinars and 33 audio lines that were open at the time of the call, when the seminar was provided. Now, the slides, the webcast, the audio, the transcript is available on the website that's shown there for the next 1 year, so that clinicians could actually go to the site, take the course, and get CME credits. And since, as of September 18, there are 21 internet registrants and 16 CMEs that were completed after the seminar was given. So physicians, at their leisure, they could go to the website and get CME courses for the course, by taking the course. Now, again, since the last meeting, we had new health education materials that were printed and distributed. And this numbered up to 10,000, and they were distributed to local health departments, to academic centers, and also CFS organizations. Again, continuing with the theme of awareness, increasing the awareness of CFS and education to different groups, mainly the local health departments. There's a lot of interest from the state and local health departments about this disease, and some of them actually have reached out and requested this education and materials. Now, Dr. Nancy Klimas mentioned about the CME courses that are being developed in collaboration with a number of groups, a number of individuals. And this course production is on track for 2012. It covers 2 areas, clinical diagnosis and management on CFS, and CFS and sleep. And the team members that are actually working on the CME courses are listed there. Now, again, continuing with the theme of education, we secured a contract with a company called Center for Advanced Professional Education. And this group actually produces standardized patients that medical schools could use in their medical education process. And the contract is basically to develop a standardized CFS patient that could be then introduced to medical schools to be incorporated into the medical school curriculum. And that contract has just been awarded. We've also secured a contract with Medscape, again to produce another CME course. This time the CME course has a different format, a round table format, and that award again has been provided to Medscape, and that will be coming in the future. Okay, switching to research. We established a collaboration with Dr. Eric Duwart's group, the Blood Systems Research Institute for Pathogen Discovery, using metagenomics. So this group is trying to identify pathogens that may be responsible for the disease. In already 50 plasma samples from patients with acute CFS onset has been submitted or sent to the center, to the institute, for exploratory study. And we just started this collaboration with Dr. Duwart. And some of you may already be aware that the data from the Wichita clinical study is now accessible via that website at the Research Data Center. So this took a long time to cure the data and make it accessible. But that website, any interested party could go to that website, actually apply for the data and access the data from that particular study, from the Wichita clinical study. And last but not least, we have issued 3 contracts for a clinical assessment of the disease, mainly to try to inform any discussions or decision-making for case definitions in the future. There have been a lot of discussions about case definitions and about harmonizing them, revising the case definition. We believe that that process has to be data-driven. So we awarded this contract to try to collect clinical data to inform decision-making and revisions to the case definition. The 3 institutes that have actually been awarded are listed there: Beth Israel Medical, and the PI is Dr. Nedelson. In neuroimmune disorder, and Dr. Klimas is the PI. In the Open Medical Institute, and the PIs and the collaborators are listed there. Although there are 3 awards, the data will be collected, I believe, from 7 different clinics. In this data, we hope, will inform future discussions about revising the case definition. Thank you.
I asked Deborah Willis-Fillinger to go next, as she has to leave early, and we delayed her from yesterday, and then we can come back, and if we have any questions for Deborah and the CDC, we can fold those in. Deborah Willis-Fillinger.
Hi, thank you. Deborah Willis-Fillinger, HRSA. Good morning. So today I've provided some basic updates based on previous conversations that we've had here at CFSAC. But before I do that, I'll do sort of the basic introduction to HRSA. HRSA is considered a health access agency, and we support direct healthcare services. We support infrastructure development, technical assistance, and continued learning for healthcare and healthcare access. So examples would be in supporting direct healthcare services. We do that through the Office of Rural Health Policy and the Community Health Center programs to rural and underserved communities. We also provide support through the Maternal and Child Health Bureau to women and children. All women and children in the United States are eligible for many of the programs that we provide, the services that we provide. People living with HIV and AIDS are supported through the HIV/AIDS Bureau there, and we also provide health professional education support and workforce development. I think one program that might be familiar is the National Health Service Corps program, and then, of course, funding to academic institutions for health professional development. An example of some of the support for technical assistance, we provide quality improvement support, technical assistance, and support for health information technology adoption for many of the grantees and programs that we support through our funding. An example of the quality learning or the continual learning that we support, I've mentioned before the quality, we call them knowledge management and learning communities, and we've talked before about some particular programs. The Patient Safety and Pharmacy Collaborative is one that I've mentioned a number of times, and another is the National Quality Campaign now for HIV is another learning community that's developed. And just the very simple basics for these learning communities is that they're grantees that work with communities and other state and local stakeholders to improve the quality of the healthcare systems that they're involved in and develop new strategies and to test quality measures. So those are just, that's a basic overview of HRSA, and I think there's a pretty good HRSA website that many of you may have visited in the past. And in terms of my report today, really what I've done is just provided you with some background, some things directly off of that public website, and in the form of some news releases that I shared with the panel. And these were just some that they pulled off as examples, but I'll just walk through very quickly. One talks about a new report developed by the Maternal and Child Health Bureau that from the National Survey on Children's Health, and this particular report is on the health and well-being of children in rural areas. And the reason I thought it might be of interest to you is because it basically, as you look at this report, it comes from the National Survey of Children's Health, which occurs every few years, and that particular web announcement also links to the National Survey of Children's Health, as well as the National Survey on children with special health care needs, and the data fields that the different surveys instrument tools are also included. So I thought that was of interest and has been mentioned in previous reports. The other news release was just an example of the work that we do in workforce support in the National Health Service Corps. Recently provided a news release that indicates that currently 10,000 National Health Service Corps members are being supported through the National Health Service Corps, providing healthcare services across the country through the National Health Service Corps. And another announcement was just an announcement about $3.4 million being supplied to various states and communities for children with special health care needs. And that's also been provided to all of the members of the advisory committee. And lastly, this is all from once again the first page of the internet at HRSA, so that can be easily found by anyone listening on the phone or here in the audience. Another thing that's on that web page is a funding announcement. And in the last meeting, I mentioned a program called Family to Families, which is I can basically read it. It's probably easier. But these are organizations that are supported by HRSA to provide support to families with children with special health care needs or disabilities, and to help them find access services and support. And that on the first page of that website, there's an announcement of new funding that will be available for that through the Affordable Care Act. It's called Family to Family Health Information Centers. So that's basically that's my very, very brief report. Thank you.
Thank you, Deborah. Does anybody have any questions for Deborah?
Deborah,
Leonard Jason.
Leonard Jason, I'm just wondering, Deborah, can you maybe point to how kind of people who have the illnesses that we deal with this advisory committee could potentially profit from some of the programs, and in specific, do you have any ideas of how we can use the resources of HRSA to actually kind of expedite some of the types of recommendations we can make to the Secretary?
As usual, Lenny, that was a very complex question. I can tell you that in the past I've reported on the various programs that we have at HRSA and the way that we don't, as an agency, prescribe an approach to care for patients of any kind. What we do is support organizations and communities that provide healthcare services based on guidelines. And so, as I've talked to you before, I think basically the most important or the key to allowing healthcare professionals who are supported through our programs to provide services that are aligned with those that we've been talking about here is for them to be able to access information about guidelines for care. And so the kinds of programs, that the CME that's being developed by CDC right now is of particular interest, because I think that might be, those are the kinds of programs that we could easily mention to the providers and give them information that would help them to access that information. But it's always been important for us to have that kind of information to support. We don't direct health professional education in terms of the kind of education that providers are required to get. But I think simply by having, as these resources start to become available to us, being able to share them would probably be the most appropriate thing.
Thank you, Deborah. So you're hereby released. If you need. Okay. So I'll go back to CDC now. If anybody had any questions relative to Ermias's presentation, Susan Levine.
Hi, I know it's probably available on your website, Susan Levine, New York. But what are some of the titles, examples of titles of publications? You mentioned that you had 5 publications since May of 11. What are the topics, and maybe mention perhaps who some of your collaborators were on these projects?
Right. Beth, I'm sure, has the list. So we will go through the list.
This is Beth Unger. One was the utilization of web-based continuing medical education courses by Markov model. One was on coping styles. Okay. Should I start all over again? Okay, this is Beth Unger.
Very good.
One was on web-based analysis of continuing medical education courses by a Markov model. One was on coping styles. One was on life stress. One was on identification of a reference gene for quantitative gene expression. And the last one was on a kinase associated with interferon alpha that's induced in fatigue.
I wanted to applaud the CDC for the path, all of that, but particularly for moving back into pathogenesis involving pathogens. That's a great sub-project. That's fantastic. And I think there's been a true move since with Beth's leadership to move the CDC in a very forward way. So congratulations.
Leonard, Jason.
Yeah, a couple questions. You know, I know that you've talked about trying to make some revisions in the current FACUDA criteria. I was wondering if you could answer maybe two questions along those lines. One has to do with many of the articles that are currently being published are still using the kind of Reeves 2005, what's called the empiric criteria. And I was wondering if you could comment on those particular publications and those criteria, and most importantly, kind of what's the process by which you're considering kind of beginning to change, and how that's going to occur, what the time frame might be, and who the people would be involved in that process.
Beth Unger, CDC. Hopefully by early next year, we will have a publication that clearly explains the comparison of the standardized approach to applying the FACUDA definition, which I don't like calling it FACUDA, it's the 1994 definition, and the approach that we had used in the past in Wichita studies. And indeed, everyone will find it very reassuring that the patient populations are quite comparable. Okay, so I think that will relieve a lot of anxiety about what is going on. One, that article will also include as supplemental material detailed explanation of actually how we did that criteria. So that is to allay the concern of the current data, that those large studies that are used that have the data collected the way we collected it. Those studies are still ongoing. The 3 studies are the registry study. I don't mean the studies are ongoing. Data analysis and testing and all of that are still going on. The clinical study that we call the GCRC study, and finishing up the follow-up surveillance study. So they all use, you know, we ask the questions the way we ask them, and we'll have that data and be able to show that. So that's sort of the first question. The second question, I will admit that I see it kind of, you know, and then a miracle will happen and the case definition will come out. I don't understand yet all of the processes. We're going to start with our clinical contract and getting advice from our clinical colleagues that are directly involved. We envision that that could possibly be a platform to engage people that do not actually have contracts to dialogue with us and with those clinicians that are involved in what are the next steps and how we should approach this. So we're going to start with the data collection, and the very first step is, and the question that's been asked over and over again, is how do the patients differ in people's practices? And is this really why we have some problems, even though everybody calls them CFS and they are using a case definition? Is that why the findings in the laboratory are not always translatable? That's just first step number 1. Then step number 2 is, if we have good measures of the domains, and you know that the field is ongoing as what are the best measures of the domains, then to try to say, how can we capture this in the best way? And we do run the risk, and I think we as a field need to be a little bit schizophrenic and say, yes, we can bring people in under a broader umbrella diagnosis, but then we can't just group cases and controls. We have to be doing some stratification. We have to use the dynamic range in all of those measures. So it's not just enough to have fatigue, but exactly how much fatigue. It's not enough to have any one measure. And the last, so even though I don't fully understand how exactly it's going to happen, going by what's happened in the past, CDC, before I got there, convened a meeting of experts, and that is indeed what will happen. CDC doesn't decide any of this on its own, and that's why I always say it's not CDC's definition for good, bad, or indifferent. Just like in the ACIP committee, CDC implements what the committees and the recommendations are, and that's how the the 1994 case definition got established. And I think 1994 is long enough ago that everybody agrees it's definitely need revisiting. But I think it will be most helpful when we actually have some data to guide that discussion. And so given that we're just at the beginning of the contract and we're just beginning to collect the data, if all goes well, we hope that we will have the data in a one-year time frame. They're one-year contracts. And so that we can anticipate that it will be at least 1 year before we could start the dialogue and the process. And I think also learning from other consensus-building organizations that I've been involved in, such as the cervical cancer screening and HPV testing, you have a meeting, but you need to have committees and discussion and dialogue up front before the meeting. And that's what's been most helpful in reaching consensus in those areas. And I would think the same process should go on, so that before the actual meeting, you have pre-meetings and you have things posted and you allow for comments and dialogue and discussion, because everybody needs to have a voice in what the final product is.
One follow-up question, if I could ask Chris, Lenny, Jason again. Again, CDC certainly has a tremendous reputation within this country as well as internationally. So anything that you folks ultimately do in collaboration with others kind of has a ripple effect throughout the whole world. There's a lot of discussion right now concerning a couple of things. One is CFSME, ME. Also, there's a new ME international consensus criteria that was published this summer. There's a Canadian criteria. I'm just wondering if you can mention at all your thinking about the different names that are being used, as well as some of these other criteria that seem to be more specific than the Fukuda criteria.
Beth Unger, CDC. Yeah, we are certainly aware of all of the new definitions and the strengths and the weaknesses, and I think it's been very helpful to get this new information and to consider what other domains and other measures should be included. And I think it will. You know, I have gotten lots of communication from people saying that CFS is different from ME. I've got people that insist that it's the same thing and synonyms. I think that there's disagreement. There is confusion in the field about whether it should be the same thing, whether it should be two things, whether it should be a hyphen name. And I think until there's clarity of what we're talking about, we can't give good guidance. And so there has to be more consensus among experts, and that's hopefully where we're starting with getting our contract initially started. This will be the beginning of the dialogue, and there's legitimate points to be made on both sides. It's separate, it's together, it's different. I don't have the answer yet.
Thank you. I wanted to clarify our contracts for a little bit, because we'd been talking about data earlier. The CAT tool, we have that contract with Boston University and National Institutes of Health. And the ICF we've been working with Stanford University on with the ICF coding. So I wanted to make sure that everybody knew that there was two different contracts with that. So they're not really working in conjunction at this point. We just have two separate things. And, you know, we go from cutting edge data discussion to what kind of data SSA currently has. And I do have to say it's somewhat limited. And we only have the old data that we had previously. We are working on developing the new data, and we expect to have that for the May 2012 meeting. Our data shop, we have a particular data specialist group, and they're working on that information. And as I understand, there's going to be a more specific request possibly through FOIA, so that they can know exactly what kind of data to pull. some of the data that I have here with me today, it's hard to compare the different charts and everything, and I'm certainly not a data specialist, so I can give you a high-level overview, and maybe orient you to the charts because they have the similar definitions on all the charts, but I wouldn't be able to give you a full analysis like a data specialist would be able to do. And maybe, what's in here? Yeah, it's in this blue folder that I gave everybody, and maybe that would give you an idea as to what you'd like to see in the future too, to see what we have already. My Associate Commissioner, Office of Disability Programs, Social Security, Art Spencer, he's planning on personally attending the meeting and presenting at the May 2012 CFSAC meeting. So I think that would be helpful to everyone to have him here and be able to talk about it more. Maybe he'll bring a data specialist with him then. Would you like for me to go through some of this?
Yeah,
just quickly.
Well, no, explain what you're seeing.
What it is? Okay.
And the definitions are on the left side.
Yes, the definitions are on the left side, and we're asked, what is Title II, what is Title 16? We have little definitions on that. Title II is when you're insured. Title 16 is income-based, so you have to have certain income level, lower income level. And when we talk about concurrent, which isn't really on this definition list, that's a person who qualifies for both. They're insured and they're also low income, so they get Title II, Title 16, so it's both. Then I just added the definition of disability and the definition of medically determinable impairment because that gives you a little bit of orientation as to what we're doing. This first chart here is the total number of initial determinations for fiscal year 2008, and like I said, it's a little old. The bottom part of the chart, it says all claims, so that's everything. Title II and Title 16, all of them, including the children. The children are Title 16. They're the SSI children. That's what we call Title 16 and SSI. We interchange those words. So when you look at all the claims, the middle number is the total number of cases adjudicated at the initial level. That's our first adjudication. We have several levels of adjudication, but the first adjudication is our initial one. So that's the total number that we adjudicated in that fiscal year. On the left is the number that were allowed, and on the right is the allowance rate, the percentage of individuals who were allowed for that fiscal year at the initial level. If that helps orient you to the chart. And this does not go into the appeals and the process with that. And if you're wanting comparisons, that might be something that we need to have a specialist deal with. But that gives you some orientation to this chart. This next chart is the most recent that I could find dealing with people, it says in the title, in current pay status, but this is individuals who are receiving disability benefits based on chronic fatigue syndrome. And this is as of May 2009. And this is whether the chronic fatigue was a primary impairment or secondary impairment. And when we document the primary and secondary impairment, it's at the time of adjudication. It's not at the time the person alleges the impairments for disability. We track it as of the time the adjudicator adjudicates the claim. So that's how we get these numbers. And over the top, you'll see Title II and Title 16, and of course, each of those have subcategories, and we always break out the children for the Title II or SSI. And then there are other categories, it's the disabled workers, but they also have the disabled widows and disabled adult children. So, but they're all under the same umbrella of Title II. And then under Title 16, we just have adult and children under that. And so that gives you a sense of what we have for the allowances. And the next three charts are really trying to look at denial counts, because there was interest in how many individuals are denied with certain kinds of conditions. And the next two are on chronic fatigue in fiscal year 2008. The first one is initial, and the second one is reconsideration. And reconsideration is our second step in adjudication. It's the second level of adjudication. And I don't think you can compare these two, or at least I'm not familiar enough to be able to compare them. And then the last one here is on multiple sclerosis. It's a denial count, but it's on multiple sclerosis. So that's the last one in your package. But I did ask, when I was preparing for this meeting, I was asking our data specialist about statistical significance. And he was looking at as chronic fatigue syndrome as a primary impairment. With all of the impairments Social Security gets, the percentage of CSS determinations as a primary impairment is less than 0.1% of our total determinations for all of our impairments. And our data specialist was of the opinion that that's too small for a statistical analysis. So maybe he can answer some more of that, but I noticed that you're wanting some kind of statistical significance. So I wanted to ask him specifically that question.
I mean, what you would, this is Nancy Lee, what you would probably better do, and a data person can do that, is you could combine 2 or 3 years.
Uh-huh.
And you get better numbers.
Maybe that's what.
And so I don't know if you've noticed, just as I speak, in the letter, that the welcome letter, we have just recently found out about all of this. Michelle has come in and pinch hit at the last minute. Let me just tell you, she really has done a yeoman's job, given that I don't think you knew you were going to do this until Thursday or Friday.
Well, I'm not, like I said, I'm really not a data person.
We have a commitment, and we've been talking with Cheryl Williams to work out the best way to have a more reasonable data request, and there seem to be some hurdles to overcome. So that's one of our goals for the spring meeting.
Nancy Klamas.
Quick question. One's just definition. What was concurrent? What did that mean?
It's both Title II and the Title 16.
So it strikes me first that the absolute count of 14,000 is far, far off from the Medicare numbers we heard yesterday, which, if you looked at the people who were under 65, that would presumably be people that came through the disability track to get their Medicare. Not entirely,
but those are prevalent. These are incident.
Oh, these are incidents. Yeah. So,
right. Yeah, I believe that's correct.
Because
those are
in current pay, I thought was prevalent.
This is, it says like initial adjudication, right?
Yes, it's only the initial. I mean, we have different levels of adjudication clear through the.
I thought the in current pay would be the people that came into the year on disability.
In current pay.
The people you're paying out at the time.
Oh, you're talking about the yellow, the second one, the second chart?
Yeah. That might be the totals. But the other thing I don't get from this, should be very helpful, is of the people who go in for appeal, how many are approved? Because you see how many are denied on this, but not of how many. You don't get the of how many. So if in the first denial there's a total of 2,800 people being denied, in the second denial there's a total of 679 being denied, but not everyone that gets denied has the courage to go back and ask, and that happens rather frequently.
And that's one thing about this data. There isn't anything in here talking about different appeal levels as far as I can tell. I mean, this one in current pay status, I'd have to get clarification as to if that's, I guess that would be any level.
Yeah.
But I would have to check and see if that's what that means.
So one of the issues of our subcommittee has been, with Social Security, has been this sense that the patients tell us that they believe that there's a regional bias, that there's places where you're more likely to get approved in the appeal than in other areas. So, there are statements, I don't know if they're factual, that there's some areas that you dare not try, that it's not going to happen. So that would be very helpful to you to know where the education needs are within the adjudication training part of that. So that's one of the things why we asked. I think you could easily collapse 5 years of data on that and get a big number. So that when you're thinking how to look in your data sets now, if you could look at regional variation, that would be really, really very helpful. But this is great. It's the first time that we've ever had any data back. So thank you.
Well, at least that anyway.
I've been on this committee off and on for more years than I care to own to, since someone noticed that I was aging earlier in this meeting. Getting older, yes.
It's also an intact whole population, so the small percentage of the total shouldn't matter because we're looking at the whole population of CFS, so that shouldn't really be an issue.
It's hugely helpful to the committee to actually have numbers.
Yes.
It's very hard to talk in generalities, and this was great, so thank you very much.
Maybe when you look at it too, you'll have more questions, and then the data specialists can help with that.
I think we will be posing more questions, but they'll be more precise because now we know what kind of data you can pop out, and that's very helpful.
That's what I was hoping, that maybe it'd be more of a precise thing.
Great, thank you.
I didn't see whose hand went up first, so I'm going to go in order of proximity. So Susan, Leonard, Steve.
This is great that we have all this data. I just was curious to know I'd like to know maybe for next time if there's a significant difference in the awarding of disability over the years. In other words, is there an incremental, hopefully, increase in the number of claims allowed, say, over the last 5 years, and what that may be due to, or if there are any changes in the adjudicators or in terms of their learning curve, about, particularly with relation to CFS?
That might be interesting, too, because I wonder if, after we issued the ruling, on chronic fatigue, if that made a difference or not. That would be interesting to see.
Lenny, Jason, and again, not just as with Nancy, I want to thank you for coming in with numbers. There's been years and years where we've asked for some of these basic data, and it's now coming in. Are you going to be our continual representative as an ex officio? I hope you are, because you're so responsible, but if not, if we could have someone like you who could basically provide us with this information. But my real question is, those numbers do seem a little bit low, the incidence numbers, and I do think that maybe we need to think about whether people are being misclassified into something else that might be easier to get disability for, whether there's any way of us teasing that apart with any information or research that your agency does. And ultimately, it might be good to compare some of that work with some of the community prevalence data on both incidence and potentially even prevalence, and just see the mismatches so we can better understand the nature of the problem.
That might be interesting because, when they record the primary and secondary impairment, it's what the adjudicator is finding, which a person may have chronic fatigue but not be in the primary or secondary impairment, and that's sort of a limitation of the data.
One of the things that Rebecca did when she was on and we put the original request together was do a list of alternative diagnoses that we were aware of that potentially people could get in lieu of chronic fatigue syndrome, so we could do some comparison there, and we might want to think about doing that again. So.
Yeah, the regulation, Steve Kravchik. The regulation, I think that's the key one, is 99-2P, which, if I understand it correctly, is a 1999 regulation. I was struck by the 36.9% that are allowed out of the 2 million claims. That was the very first chart you showed. Yes. And it would be interesting to know that kind of information for chronic fatigue syndrome. And I'm struck too, chronic fatigue syndrome, a lot of times the Social Security attorneys, rather than fight the chronic fatigue syndrome, will go for a mental health classification. And that may account for some of the poor data on chronic fatigue syndrome. It isn't a mental health condition, and that's part of the problem with the whole system. So I don't know, it'd be helpful to also see the appeals, what happened in the chronic fatigue population in particular. Because my understanding is that a lot of people get denied, and the general sense is, I'm going to get denied by Social Security at the initial and reconsideration level, but when I get an attorney and I go and fight it, then I'm going to get my benefits. And that seems to be what I hear from the Social Security attorneys that I know and refer people to. So anyway, the appeals would be important.
Eileen Holderman.
Eileen Holderman. Thank you, Michelle. I agree with everyone. This is great data. My question is, how do you want to proceed from here? Because right before CFSAC meetings, Dr. Lee and others ask us for questions that we would like the ex officios to ask. And I know that I submitted a huge list of requests from SSA. So how do you want to proceed from here? Do you want to, so that we don't keep asking the same questions, or what is your capacity to give it, like from the list that I gave? In other words, are you going to give me feedback and say, you know, Eileen, I answered this portion, and hopefully, you know, next time we'll get to this. Like, how do you want to work together on that?
This is Michelle. I think that we probably could go through the list again and see, because there was some that I think have been answered previously, or you didn't think that they had been?
Well, Rebecca had submitted some questions, and other CFSAC members had in years past, but I think I looked at her documents. It might have been going back as far as 2005, and so when she did finally get a response, I think she said it didn't quite meet the expectations that she had hoped. It was short. It certainly wasn't anything to the quality of what you've submitted, and data has changed, and we understand your system has updated and is much more technologically savvy now. So I just wanted to know what the process would be so we could work together.
This is Michelle again. Is it a data question or is it a policy question?
Both.
Maybe
you know,
both.
as we are asked to submit requests for data, how would you like to do that? Because I did give a long list, and I'm not sure what all was like covered.
Can I just add to this? This is Nancy Lee. Those questions, as you know, were given to Cheryl Williams, the ex officio, and we all went back and forth the last 2 or 3 weeks. I don't know if Michelle was given those questions, but it was just Wednesday or Thursday that Cheryl told us she was not going to be able to be here.
Okay.
And so we had been working, actually these tables were originally provided to us by Cheryl. And so we had been working with her to clarify and actually define some of these things, which is what Michelle has provided to us. So I think with the last minute change and Cheryl here, that we did not get those questions addressed. And I think some of them may have already been answered, but I don't even know if Michelle has a copy.
I was looking through my things I brought with me. I didn't see them. But,
okay. I can get you a copy, but in the meantime,
it's a transition stuff.
I agree with Lenny that we're just grateful to get this type of information, and in such an easy format to understand and read. Thank you.
Yes, thank you very much, Michelle. The data that Rebecca asked for, we got data. It did not appear to answer the questions we thought we'd asked, but we may not have asked the questions very well, so it's worth trying again. The other point that I'd just like to make is that the ex officios are on the subcommittees, and if they can take part in those telephone conversations that occur in between meetings, a lot of that work can be done in terms of discussing what questions can be answered and how best to ask them. So it is helpful if the ex officios can make the telephone conversations. And Steve just had a
Yeah.
follow-up question.
Do you know where the data on chronic fatigue comes from? Is that from only the ones that went to an ALJ decision, or are they reconsideration? How do you know what's where do you get the primary and the secondary basis?
At any level, the adjudicators record primary and secondary impairment codes. They all record the impairment codes. But the only thing I know about the data is, what the data specialist told me, this one's initial, this one is initial, and this one's reconsideration. And I didn't bring any ALJ data. That'd be the third level of appeal today, but I'm sure that they have that,
Okay, so then it's very clear that the prevalence data is way off.
Okay, thank you very much. Still pressed for time, so I'd like to move on to the NIH report. And Charles.
Actually,
oh, sorry.
So I'd like to just give a couple of introductory comments
Janine.
Thanks. Janine Austin-Clayton from NIH. I'm really pleased to be here today. I know that many of you are aware of some changes that are ongoing at NIH, so I just wanted to address those first. As you know, Dr. Vivian Penn, who was the director of the Office of Research in Women's Health, through which the NIH the Trans NIH ME CFS Research Working Group is managed, retired very recently, 8 weeks ago. In the interim, after Dr. Sure. Sorry. In the interim, Dr. Collins has announced that I've been appointed acting director of the office, so I am pleased to be here. And I wanted to also extend Dr. Megan's well wishes. He specifically wanted to share well wishes with the committee and with those members of the public attending. And as you know, Dr. Mangan retired less than 8 weeks ago. So there are many changes ongoing at NIH, in ORWH specifically, and I just ask that you be aware of those as we move forward. As acting director of the office, I assure you that I remain committed, and the office remains committed, as does NIH, to continue the momentum that has been developed over the last 2 years to advance research on ME/CFS. And to that end, I'm happy to report that Dr. Charles Wells, who is a senior advisor in our office, has agreed to be the NIH ex officio member of CFSAC. Dr. Wells will also be the point person for CFS in the Office of Research on Women's Health. So we're particularly delighted that he has agreed to take that on. He has been at NIH for 26 years and in the Office of Research on Women's Health for 5, going on 6 years. So also, in the interest, one of my concepts that I'm working on in the office is working teams and redundancy. And I would also like to introduce Dr. Candace Tingen, who is here in the audience. Candace is a AAAS, American Association of the Advancement of Science Fellow, who works in the ORWH, and she's going to bring her strong communication skills and her research background to help us move things forward. So a couple of more people that will be helping to work on that, and then CFS within the office will be also part of our research working team, which has many other members on it. So just with that being said, we'll turn it over to Dr. Wells.
This is going to be very brief because I know you're ready for lunch. And I am, like Dr. Clayton said, I'm very new. I learned that I would be making this presentation about a week ago. So you all should be very kind to me because I'm new. What I'm going to do is sort of give you a bird's eye view of what has happened since the last meeting. And as Dr. Clayton said, Dennis retired from federal service. So I'm waiting a few minutes for I have several slides. Is that better? Okay. Oh, great.
View.
Okay, my first slide here is just to give you an overview of some of the CFS ME activities at NIH and also with HHS. All of you aware of the fact that the NIH blood study was unable to identify the virus in any blood samples. That's not new news, but there was a study done at the NIH. NIH is also doing sort of, when I say NIH, many times I mean trans NIH. It's more than just one IC doing its work. So I'll get into that later. But there's a clinical study looking for other retroviruses in a large cohort of CFS patients. And if you have any more detailed questions about that, there are experts here from NIAID to assist us with that. NIH is also going to release, also has organized spatial emphasis panels in the Center for Scientific Review to review all of the ME CFS applications. Dr. Cheryl Kitt from that program is here also, who's going to talk later about that new special emphasis panel and about the review of some of the applications for CFS and ME. Currently at NIH, during fiscal year 2011, we funded 20 grants that are relevant to ME and CFS. And I have just sort of selected about 8 to give you an idea of what these grants were about. If you want more detailed information on these grants, they're on our site, which I'll give you later. But you can see that we're doing one with comorbidity chronic pain conditions. That's in the Dental Craniofacial Institute. Stress effects on viral reactivity, that's NIAID. And we are busy trying to develop better animal models to study CFS. And I will talk about that more later because from our state-of-the-art workshop, we have some information about that. And we have NAMS working on the grant to develop more comprehensive molecular profiling of CFS. Neurology Institute is looking at neuropathic abnormalities, and neurologists are also looking at brain mesh cells in CFS. If you want more information on the other 12, you can contact me, or I'll give you the site where there are abstracts on these grants. Keep in mind now that these grants were funded in FY 2011, so there probably is not really a progress report out yet, but in a few months, we will have progress reports on all of these grants, and maybe by the next meeting, which I don't know the schedule, I can bring you more detailed information about all of these grants and what our findings were. Now, at NIH, we work as a trans NIH ME CFS working group. Our office sort of organizes these activities, but at the NIH, we have roughly 28 ICs. And you can see that we have reps from 17 of the 28 ICs that work on the trans NIH ME CFS working group. We have monthly meetings, we have outreach, we have a website, and we have an email listserv. And if you're not on our listserv, you can contact me later and I can tell you how you can join our listserv if you, in the event you're interested. One big activity since the last meeting was our State of the Knowledge workshop on ME CFS that was held at the NIH. We had 32 investigators with expertise in basic clinical and translational science. I don't know if we had any experts there on reverse translation science, but being NIH probably by our next SOK workshop, we'll probably have some experts on reverse translation science. This was watched by roughly 900 viewers by our NIH video cast, and there were 100 persons attendees at the meeting. We also had a grant writing workshop at the CFS meeting conference up in Canada on September 11th. And we are also right now in the preparation reissuing the EME CFS program announcement. And that announcement was, the mechanism of support would be the basic one we use in NIH, the R01, and we're also going to have R21s. I'm sort of doing this backwards, but the purpose of the SOK workshop was to bring together patients, advocates, and scientists to review and discuss opportunities and gaps in ME CFS. This workshop report is published on our website. This is the report. It went online in mid-August of this year, and as of this week, we've had 4,000 people to download a copy of this particular workshop report. If you're interested in downloading this, this is the address here at the bottom. It's pretty long, and if you don't have time to write it down, please contact me and I can send it to you, or just send you a copy of the report. The report is available in electronic copy, of course, and we also have hard copies in the event you want hard copies. So if you want hard copies, you can go to the site or you can call me directly. My phone number, I guess is in the program, but it's 301-402-0361. Next. At the workshop, we sort of broke out the reports on research gaps in terms of ME CFS research. And now, keep in mind that this workshop was dealing with the state of the knowledge for research. So the gaps and opportunity that I will speak here are dealing with research. At this workshop, some of the gaps identified was many of the studies are in the literature have not very strong research design studies. There's not a lot known about the etiology. Of course, you know that better than I know about ME and CFS, which is one of the other gaps. As was discussed yesterday, there are a lack of validated biomarkers. There also is a lack of case definitions and diagnosis. It was also stressed there is a need for more genetic studies. Also, I'd like to add there's also was felt that now with the new discipline of synthetic biology, there should be more experts in that. And also there was also articulated that there should be more of a system biology approach to look at some of these issues. And as you know, as well as I know, that they felt that we need more investigators. And certainly at NIH, we are stressing programs to stimulate more young investigators. And it was felt that for ME/CFS, this would be a good time for a lot of new investigators to really get some exposure and some training to do ME/CFS research. Now, there were a lot of research opportunities identified also at this State of the Knowledge workshop. And some of the opportunities that, you know, that are really still needed or need to be investigated, advances in neurology, improving bioimaging. There's always a need for better communication and outreach.
Charles, we're going to run out of time if we're not careful, and I know that, that we're likely to have some questions.
Okay.
What I would suggest is that the website's been made available. We can go and review the outcomes of the State of the Knowledge Conference through that. So,
okay, then I'll go ahead and next slide, please. I think. Okay. Anyway, that was the last slide, so thank you. Now, we had planned, if it's possible, to have Dr. Cheryl Kitt to speak about the spatial emphasis panel that NIH organized to review ME-CFS applications, if that is possible, and I don't know, she's been here several hours, I don't know if she can spend the afternoon here.
To 12:45 for 30 minutes. Okay, so
Just one question. Do we have people that are going to be, we're going to phone? Do we have people for public content that we're phoning? I know we have Charlotte Gonzalez. Well, she's the reason I asked, because we try to do the public comment at the time we said.
yes, that was my goal to.
Chris, just a point of order. Cheryl Kitt has been such an active member of our group for years. Having her in the audience and having her have a chance to make a couple of comments, I think, would be extremely helpful.
Yeah.
Thanks, Dr. Jason.
My suggestion is that if Cheryl could move up to
then I will stop here, and we will hear some comments from Dr. Kitt.
We do appreciate that, Charles. Thank you.
I feel that I was cheated in terms of time, but anyway, this is my first presentation, so in the future I will
You were.
keep that
I'll
in mind.
acknowledge
Okay.
that, and I'll take full responsibility. And if you want to throw me off the committee, that's fine.
No, I wasn't suggestive at all.
He's getting thrown off anyway, so don't worry about it.
Dr. Kitt, what you say?
I'm Cheryl Kitt, the Deputy Director at the NIH Center for Scientific Review, and I thank the gentleman from my sister office at the Office of Research on Women's Health for providing me with time. So I wanted to let you know that the Center for Scientific Review funds nothing, but we do review grant applications, and we receive all grant applications that come to the NIH. The CSR is also the home for the congressionally mandated Special Emphasis Panel on Chronic Fatigue Syndrome. The congressional mandate for this study section has really been in effect for more than a decade. And I must tell you that even though we don't make any funding decisions, the institutes do. So the deliberations of our study sections, and in fact, I'm looking around the table, many of our members, of your members, have served on the committee. So they know what goes on in the committee. They also apply themselves. The problem, though, as you heard Charles allude to a minute ago, is that we receive very few applications. Over the last 2 years, we have received between 6 and 20 applications per study section. So, and I've mentioned this over the years, I think that a real effort has to be made to encourage investigators to get interested in your conditions. Partner with them, train them, but the NIH really can't fund applications it doesn't see. The success rate is pretty high for applications that to be funded because the denominator is small. There aren't that many. And so you need to realize that in order to be successful in improving the health of individuals with chronic fatigue syndrome, people need to do research and be encouraged to apply for research support to do so. And so the Special Emphasis Panel changes expertise every few months. This panel meets 3 times a year. And the expertise, we try to bring back some of the same people, and many of you are CFS experts, is dependent on the applications we see. It's hard to have a standing committee with set expertise when, in fact, the applications change almost every few months. And so the committee will continue. The other issue you should be aware of is that if an applicant is not just studying chronic fatigue syndrome and requests that their application be reviewed in other study sections based on the science, their applications will likely be reviewed there. Now, you should ask whether they do better if they go out of the CFS study section, but I think I told you earlier, the success rate's really quite high in the CFS study section because the number of applications is low. So it may give a false impression about relative success. But the bottom line, whether applicants are being reviewed in the CFS special emphasis panel or in any other study sections, the number of applications is small. Between 6 and a high of 18 over the last 2 years. So over the last 2 years, we've convened 6 study sections.
For people that don't do study sections, give them a perspective. Galen Marshall.
Oh, yeah, I'll give you a point of reference.
How many that is.
So a standing committee usually reviews on average 60 applications to over 100 in a specific study section. We have 240 standing study sections and about 1,000 special emphasis panels. So it's that number of applications would not support a standing committee.
Nancy Klimas, followed by Leonard Jason.
And this is really for both of you. First, is that an increasing or static number? What do you think?
It's pretty static. It's been this little roller coaster. I've looked at it for the past 10 years, actually. I just wanted to report on the more recent ones because there have been changes in peer review over the last 2 years. The applications got smaller, the criteria are somewhat the same, but they're all scored. Everyone receives scores. And so this is also about impact. Will your research make a difference? So the priority scores that applicants receive is based on whether this research as a package will make a difference in clinical practice, patient care, in the scientific field. And it's really the burden of the applicant to write it that way. We don't think that the scores, the relative number of applications hasn't changed because of that. It's just the way it is. The other thing that I've noticed, particularly in the past few years, is that if an individual is funded the first time, they tend not to come back in the second time for some reason. Either the results were so positive that they are doing something else, or the results weren't so positive.
So you're not getting renewal applications?
We're not getting competitive renewals very often, no.
That's interesting. Mm-hmm. I have a question about, I think that some of the things that could encourage additional investigators could come from the NIH, most assuredly, in the form of training grants, having a way to get at training grants. It's not in our program announcement. It's not, in our 21R01 program announcement limits to our 21R01s. We don't have an easy way to come in with clinical trials applications, and that's where we're at in our field. So we have a big problem there. That's a really big deal. And finally, using an interagency coordinating committee to try to patch together the funding has dramatically limited access to program projects and center grants. And so if there's some way to tackle that head on, because it's been a recurrent theme, we've mentioned it many times. I know that when the NIH has tried to jumpstart fields in the past, say the whole field of geriatrics, I mean, there was a way to the whole Center of Aging went from a sketch area of doing science to one of the most, predominant and well-respected areas of doing science, mainly because the NIH really made a full court press effort to draw people from other fields into the field, encourage K awards, encourage training grants, encourage centers and programs. And that is the way to jumpstart a field, is to get that kind of collaborative and sort of total program idea behind the funding structure.
And I think those are great ideas. With regard to centers, I know that the Office of Research on Women's Health at NIH had supported centers. The Specialized Centers of Research had components on CFS or temporal mandibular disorders that really are important. But what happens to the trainees or the fellows on those? They tend not to continue on with their independent research. So the other thing I wanted to mention, you mentioned, Nancy, the collaboration. So there's no reason not to put collaborative, multi-investigator applications together. I could see collaborations in the room as well. There's nothing preventing that with some training slots on your R01s. By the way, most fellows get trained on R01s and not training grants, including myself. I wasn't ever on a training grant. But most investigators are being trained not on training grants. That doesn't mean that an institution shouldn't submit one. You can contact program staff in the Neurology Institute, the Arthritis Institute, wherever you wish, and discuss with them what your training program may look like. So that's one. The other thing is fellowships. The F32s, these are for postdoctoral PhD individuals. We haven't seen any over the last 2 years at the very minimum. There are no fellows coming in. So if you have fellows in your labs, please encourage them and help them write their fellowship applications. The fellowships, the career awards with a K, particularly have a much higher success rate than R01s or R21s. I mentioned the last time, and this practice is still in effect through NIH, the new investigators. There's a different pay line that's beneficial to new people who have never had NIH support within 10 years of their terminal degrees. There's a differential, almost twice as good pay line for those individuals. So if you have people working with you or know of people who want to enter this field, R01 is really the way to go. It would provide 5 years of support, and really, and the institutes are looking for them. The institutes have a mandate to try to fund as many new investigators, early stage investigators, as possible. But I could tell you, in the last 2 years, there were no new investigators in chronic fatigue syndrome that were reviewed, none. So that's a problem. I mean, it's a problem for the field that for some reason new investigators are not even submitting applications. But I would urge you to encourage people to do that.
Charles, question for you first. Certainly we welcome you to the group, and with very short notice, I think you did a very good, comprehensive presentation. The question I have for you, and also for the Office of Research Women's Health, is that Dennis was such a magnate, sort of a person who generated such goodwill among the scientific and the patient community. And Hannah before that, that there's been a sequence of people that we've developed trust, we've developed knowledge, they've become really familiar with the system, and yet there's been changes that have occurred. And not only, again, with this particular office, but with other entities. So I guess the question is, how do we figure out a way of getting more stability so that that year and a half or two that one learns everything and learns the connection, learns the people, learns the field, can then profit the CFSAC in a better way so that we can then kind of work collaboratively. So that's one question. And for Dr. Kitt, I guess the question I'd like to ask you is that, certainly your SRO is a person who cares, who really is I think has the trust of a lot of researchers. Your message to us repeatedly is, how do we get more applications? I think that's important for us to hear. On the other hand, what I hear from investigators is that because it's a special emphasis panel, sometimes the membership changes so that the reviewers on one panel are different for the next review when the revision comes in, and they have new sets of issues that sometimes come up. So I guess I recognize you can't have a standing committee without the more applications, but how do we deal with this issue of kind of an individual who kind of brings in a revised application, addresses the issues, and then has a whole new set of concerns that come up, and then they are once again discouraged?
Thanks, Dr. Jason. I think the first question I will direct to our acting director in terms of what she can say in terms of the recruitment or what I would be the permanent person, but I would assure you that we're pretty lucky. And in my office, most individuals who take on a task are pretty seasoned and pretty committed. And just hopefully we won't get someone who's close to retirement, because we can't control that.
So I can assure you that as a clinician, I was really, this is not my first CFSAC meeting, by the way. I actually came before I was in the office, and I was on a detail to ORWH, and Eleanor Hanna was here. So I just came when I was interested. But I was, as a clinician, I have to say, I was profoundly touched yesterday. I've heard public testimony. We included it in our strategic planning process in 5 meetings, all of our meetings. But I am specifically committed to helping to continue the momentum. The continuity is an issue. I recognize that. And I'm hopeful that because I was backing up Dennis was reporting to me. I was supervising Dennis. So he was reporting to me all along in the last few years, and he was absolutely fantastic. We all agree. But I hope that I can provide some of that continuity, and then also the strategy that I've developed to organize the office around these working teams to develop some redundancy and sustainability within the office, I think will serve that as well. It's frustrating. You know, I think we're all in that situation, but I hope that you will be willing to kind of look at this in a new way. This is new leadership, 20 years of the same leader. This is a new time. So I really am encouraged about hearing all of the interest from all the folks around the table. And as a former clinical investigator, I recognize these issues, you know, and so we have to work together, and we have to find creative ways to work together to be able to do things in these constrained environments. But there are creative ways to capitalize on existing investments, and one of the things we've been doing in the working group meetings is to look at best practices, what has worked across NIH, what networks have, what struggles they've gone through so that they're not repeated, what we could learn from them for CFS. So we really are committed to continuing it. I recognize that it's frustrating to have a new person every time, but I'm hopeful that the things I've put in place will make that less difficult in the future.
If I can just comment on Lenny's question about continuity of reviewers. So this is not unique to this special emphasis panel. It's true of every study section. We don't guarantee continuity of reviewers for many reasons, not the least of which is not everyone's always available the next time. And if they have an application themselves, they will be recused from the meeting. And since the number of applications is small, the number of reviewers we use is small, there's always the possibility of disclosing a reviewer's identity, which we can never do. But we do particularly watch this for this special emphasis panel to at least have one person return, and more if needed. It's really based on the expertise, but I could assure you the applications are different every time, so we need different people to come in.
So Steve Kravchik, I'll take one more question after that, Nancy, and then we'll adjourn for lunch and reconvene at 1:30. And we're going to call the people at telephone conference for the public comment to rearrange that time. So Steve, and then Nancy, and then lunch.
Yeah, I just had, it sounds like, and I'm sorry I missed it, but the State of Knowledge meeting sounded like a fabulous meeting. Maybe the next step would be to do a state of treatment meeting so that all the people who are treating chronic fatigue syndrome can share an approach and maybe come up with some shared knowledge in that area.
Sounds like a great suggestion. Thanks.
More for Janine. In the trans NIH working group, is there intramural and extramural both in that group, or is it all extramural? Because what I'm worried about is clinical trials. We can't get these clinical trials done. There's no avenue to get them done. And if we could work with the intramural group, the clinical trials group at NIH, to try to get some of this early work done, it could be very helpful in collaboration with the extramural folks.
So the Trans NIH MECFS Research Working Group has membership from 17 institutes and centers, not specifically the intramural program. As you know, funding through intramural and extramural are distinctly different. Intramural represents about 10% of the entire NIH budget, and there are specific ways that intramural can collaborate. One of those is called a bench-to-bedside award. Maybe it should be called a bedside-to-bench award, but it's a bench-to-bedside award that allows intramural investigators to collaborate with extramural investigators, a very specific mechanism. So I would recommend that specific mechanism, and I can put you in touch with the folks in John Gallen's office who oversee that program to identify the next dates and see if we can match you up with somebody in intramural to be able to pursue that. I recognize the frustration regarding the clinical trials. Again, multiple PIs are an issue. These are issues that we will take back to the working group, and I will ask the working group for their recommendations. And we really are coordinating and facilitating and trying to provide that thinking space and a strategic coordination space for things to happen between the ICs, because as we are in this environment, it has to happen that way. In order to move things forward, we really do need to work together. So I will definitely take that back, because clearly once you get something you want to test, you're anxious to test it, and patients and care providers are anxious to get those studies done.
Can our program announcement include clinical trials?
So the working group is reviewing that now, and I'll take a look at that. I haven't reviewed it in detail to date, but I'll take that back. Thanks.
Thank you very much, and thanks for all the good information. So reconvene promptly at 1:30 for patient public comment. Thank you.